Okay, I'm recording now. So Olivia, put yours back in the chat because the chat won't record it before I started. So thank you.
Professor, for week 7's group project, are we in the same groups?
Mhm.
Okay, so we
Yeah.
just have to get with the same people to pick a infectious disease.
Yeah, and there's a website in the module to go on and pick your infectious disease. You see that, Mary?
Yes, I'm sorry. I'm looking at the assignment details right now too.
Okay, yep.
I just
can
wanted to
go-
be sure we're with the
Yeah.
same people.
I can go over that. Mhm. So if everybody could put their name and their campus in the chat, if you already haven't, that'd be fantastic. Welcome to week 4 of community. Hard to believe we're at week 4. I'll just wait a couple more minutes for anybody else to come in and then we'll get going. I'd like to do a review of last week, the topics from last week, the rural and migrant health, the vulnerable populations, the poverty, the homelessness, and the alcohol, tobacco, and other drug. I'd like to do a review of that. And then we'll cover this week's content as well. And then we're going to do a case study on cultural competence. Okay. I think we have almost everybody in here. Okay, we'll get started. So again, happy Wednesday. We posted you got the exams grade posted Saturday. I had sent out a email, I think Saturday evening, with a whole bunch of dates for reviews. And I only heard back from one student. I actually heard back from 2, but I had a meeting with one student last night and they didn't come. So I'm down to one student. So only one student took advantage of the review. I think it's really important, especially if you score below a 78, to review the exam to see what concepts you missed, and do some extra tutoring. All the exams are, the information and content will be reflected on the HESI. So I would encourage you to review the exam, and that goes with anybody who scored above 78. I have students that score in the 90s that want to see the couple of questions they got wrong. So it's totally up to you, but I would encourage it. Jessica, send me an email, okay? I'm not going to remember that from the chat. Was that Jessica or Jasenia? Where's Jessica? Where's Jessica?
Jasenia.
There you are. Oh, Jacini, sorry. Yeah, send me an email, okay? So what did you, let's just do a quick review of the exam. What did you think of the exam? I only had 3 students go to a live review, 3 out of 25. So I don't know if you listened to recordings. Did you listen to recordings?
Yes, ma'am.
Yes, no? Because you had, I think, about 7 recordings to listen to. Well, what did you think? Did you prepare with the study guide?
The live sessions were really helpful.
Say
Oh,
that
the-
again, Jennifer.
The live sessions were really helpful.
The review sessions?
Mhm.
Yeah, good. Okay. What's some other feedback? Did you feel like the study guide was a good representation of what was covered on the exam?
Yes.
Anybody? Other than, what'd you guys think?
I thought it was helpful.
Okay. Okay. I had a question about the week 7 group project. Yes, you are still in the same groups. And there is a website. Let me go back and there's a website that you need to click onto. Mary, did you find that website? There's a website that somebody in the group
I
needs to
did.
click,
It was,
click
it was-
on to, go ahead.
I'm sorry, I did. It was an announcement for week 4.
Okay.
There was the link to the website. Thank
Okay,
you.
so somebody in the group needs to go on, or you can all decide which infectious disease you want to pick. And then just one person needs to send me an email about what you're going to choose. I just want to make sure that there's not a bunch of overlap. Okay. And then that's due in week 7. In week 8, I'd like to spend a portion of class just doing quick presentations of your paper. And it's essentially having your paper in front of you, and you as a group just give us a 2-3 minute synopsis of your topic. Okay, how does that sound? There's no extra work in that. You have already written the paper, you've already submitted it. I just want you to talk about it to the rest of the class. Okay, so nothing to stress about, just more participation and engagement in the class. Okay, does anybody have any questions before we get going on week 3 and 4 content? I hope to have exam 2 study guide out to you this week. And that will cover weeks 3, 4, and 5. And so today we'll cover weeks 3 and 4, and then next week is week 5 already. So you're already looking at the exam review schedule for next week, believe it or not. So when you guys have a minute, take a look at that master review schedule that we sent out in week 1 and look for, I'm not sure what Colleen, Professor Price color coded it nicely. There's one color that's all the exam 2 reviews. So if everybody would have a look at that for next week and see if they can attend any reviews. Okay. Okay, so let's talk about, let me share my screen. I always show you guys the book, right? I just want to remind you, I'm not going to all the chapters in the book. Last week, okay, I'm not going to do that. I'm not going to do that. Gosh, so many people are having problems with Zoom. Are you guys having problems with,
Zoom.
pardon me?
I just had to switch to Zoom on my phone because
Yeah.
it wasn't working. I had to switch from my computer
Yeah.
to my
And what I'm hearing from lots of other faculty and lots of other students is there's just some big problems with Zoom right now. So I'm not going to be able to share my screen. So make sure when you go to, the chapters to review them, you first look at the objectives, right? We talked about that in previous classes, right? Let me just do a quick check here. Megan, there you are, or Paula, there you are. Karen, I can't see you. There you are. Now I can. Okay. So
Sorry, I was just getting my charger.
oh, no worries. So make sure when you go to the chapters in the book, you are looking at the objectives. Okay, you do not have to read every chapter from start to finish. Okay, you need to read the parts of the chapter that support you being able to articulate the objectives. Okay, I've said that a few times already, and I mean that. Okay, so it's impossible for you to read every chapter from start to finish, and that's not the intent. The objectives support understanding the concept that's provided in that chapter. So I would look at the objectives. You have a couple of links below. You have keywords, right? If you don't understand the words, you have links, so they're all hyperlinked. And then also the chapter outline. A lot of the times when you go to the objectives, you can go right back up to the chapter outline, and it has that topic right there in the chapter outline. You hyperlink and click that, and it takes you right to the section for the objective, right? Everybody knows what I'm talking about, right? That's the way to tackle these chapters, not reading it start to finish. Okay. If you can articulate the objectives for the chapter, then you're going to understand the concept. And then remember, there's a couple things to review in each chapter. Your levels of prevention boxes, it's in every chapter, and the levels of prevention are geared towards whatever the content is, whether it's rural, whether it's migrant, whether it's vulnerable populations, those objectives, those levels of prevention are geared towards that population. Okay, so the more you can read every chapter, let's see, we have six chapters, 3 from last week, 3 from this week. Go into all those 6 chapters and read those levels of prevention boxes. Okay, a primary level prevention for a rural health population is going to look different than a primary intervention for a parish nurse, right? A tertiary level of intervention is going to look different for a homeless person than it is going to look for a hospice nurse. Okay, so each of those boxes in each chapter give you an overview of those 3 levels of intervention for that particular population. And then the other box that you need to review in the chapters is your Healthy People 2030. Okay, there's several questions on each exam that go to Healthy People 2030. So I don't know if you want to put those on an index card or however you want to remember them, but when you get your study guide and it says review Healthy People 2030 for rural populations, what does that tell you? Go back to chapter 24, right? Rural health, and review that box, because you're probably going to get a question about it. And then what was the third box? What was the third area that you guys remember that I told you we need to review for each chapter? You had an exam question about it.
Was it about CUSIN?
Yeah. Yep. That's exactly what it was. And what is CUSIN? What are they? What does CUSIN stand for?
It's like competencies for nursing.
Yep. Competencies. It stands for quality, safety, and education. Right? There are 6 competencies that quality, safety, and nursing education identifies. Those are in your first chapter. And those are the competencies that nursing is based around. And you'll notice that in each chapter, CUSIN picks one of those 6 competencies. And it addresses how that competency whether it's patient safety, whether it's informatics. It addresses how that competency folds into whatever topic is being covered in that chapter. So those are the three important parts of each chapter. There's actually four. The objectives, you have to be able to articulate the objectives. Use your hyperlinks to keywords and use your hyperlinks in the outline. And then your three boxes, levels of prevention, healthy people 2030, and your QSIN box. If that's what you pull out of each chapter, that's all you need. Okay. Questions? Really trying to hone in and focus on what you need to get out of each chapter. It's not everything. Okay, anybody have any questions about that? So hope to get your study guide to you this week. I know it's being worked on. So let's go back to last week. So what did you guys learn about the rural communities, migrant health? What did you guys learn about? What's a rural community? Anybody live in a rural community? Or have family, friends, relatives that live in a rural community?
I live in a small cow town. That counts.
What's a small cow town, Jacob?
I live in Okeechobee, Florida. I actually live right on a cow pasture, right next door. Got
Okay.
one hospital, a couple of community health centers, that kind of stuff.
So that sounds pretty rural. Right now, I'm living in rural America. I told you guys I was traveling last weekend. I'm way up in Northwest Wisconsin. It's a bit chilly up here. Very chilly. It's like a tundra, to be honest. But anyway, I'm way up here in rural Northwest Wisconsin. There's not much. Okay, there two health. I split two counties. The two health departments are like little schoolhouses. Okay, you have to drive. You know, the closest clinic is 20-25 minutes away. Small clinic, no specialty docs up here, right? So if you have a high risk pregnancy, there's no high risk OBs up here. No cardiologists, no pediatricians in this little community. You have to drive. Okay. So what do we think we know about rural communities? What kind of access do they have to healthcare?
Limited.
Very limited. Right? It may be a family physician, it may be a primary care physician, and who knows what their additional specialty is. Maybe it's pediatrics, maybe it's oncology, maybe it's ortho, who knows? So what's the makeup of the rural population? What do we know about their health?
They're in poor health.
And why are they, why is their health more challenging than, say, their urban counterparts? Why?
Less resources.
Less resources, that's one.
The distance between the resources and the care that they have available. Sometimes they don't have access to specialty clinics. Their outpatient clinics don't have all the same things that they need, or like even like education is less because like there's travel for that. They sometimes have one school system.
Right.
They're usually not
Thanks,
getting
Devin.
preventative care.
That's a big one.
Yeah, they go to the hospital when they're about to die, pretty much.
Yeah, why aren't they into preventative care?
They just live so far away from a doctor's office.
Mhm.
It's just not realistic for them to drive an hour, you know, every month to see a doctor.
Mhm.
And it's their lifestyle too. They're usually people who work in agriculture. You know, they're working all day.
What about do a lot of them have health insurance?
No.
What happens when you don't have health insurance and you don't have vacation days and you don't have personal days to take off to go into the next biggest, you know, for us, the next biggest city up here is Eau Claire. That's an hour and a half away. So what happens? I mean, can they even afford to take the day off to go travel to the cities to go for MRI or CAT scan or whatever.
No, it's kind of like a financial burden for them.
Exactly. It's a financial burden for them to take the day off because they're not getting paid. Right? We know that the rural population, the major, it has a much higher poverty level of individuals and families. Okay. What would be some barriers for them? We talked about transportation. What about culture? Do we have a lot of different cultures living in different rural communities?
Yeah, speaking the
Yes.
language.
Language barriers. Right?
Yeah.
We have a big Amish community living right outside our city.
Yeah. Yep. Who do we think are most at risk in the rural community? Who's at risk?
The elderly and the babies.
The elderly population and the kids. Right? Kids are at the highest risk. Okay, in the rural population. A couple of other groups that are have a higher incidence of poverty are the single parent families. Hispanic populations in the rural community have a high poverty rate. We haven't even got to the migrants yet. What about the education level of the rural communities? Higher, lower?
Lower.
And what kinds of consequences might that bring? I'm thinking about thinking through decisions and thinking through things. The higher education level you have, maybe the better outcomes you have because you can think through and process and make decisions based on that. Right? So education is a real issue in the rural communities. Okay. What about unemployment? Do we think that's an issue?
Limited jobs.
Yeah. Limited jobs and maybe very low paying jobs.
Okeechobee.
What if you were a nurse in the rural community? Maybe if you're a nurse in the rural community, you got a big job. Right? Talk about bringing all your tools together. Right? You may be the school nurse, you may be the labor and delivery nurse, you may be the primary care nurse.
That's
Hospice.
also stressful too, because when you go back to education and the lack sometimes thereof, I'm like Jacob as well. I'm in Okeechobee, and we don't deliver babies at our hospital from incidents prior, and we're kind of, I guess, we're in a rural community. Sounds a little bigger than yours though. So all of our patients have to go to 30 minutes away, 45 minutes away to Fort Pierce for that reason.
And what if there's a problem?
Then there's a major problem.
Yeah. Yeah. There's a major problem. Absolutely. What else about rural population? Well, why do we think that we don't see this population in our urgent cares and our clinics and our hospitals until things are at a crisis level or their condition, their disease is advanced? Why? We already talked about transportation. Go ahead.
At a crisis level, I guess is more important or more panic mode, and as far as people looking for finances and insurance at that crisis time, more people are able to be more accepted because there's such a I guess a pandemic and what we went through. So
The one thing
There's
I ever
also
had,
a level of pride there too, of especially in the male population, of you need to be able to take care of your family, you need to provide, you need to work, you know, you can't take a day off, you can't be sick. And until it gets to the point where it's really, really bad, they won't go.
It's just a way of life, pretty much. It's a mindset.
right? Yeah.
They, they get sick and they think it's just a cold, but it could be something more serious than that. But because of their pride and because of the way they were raised, hardworking, they ain't going to seek out any help because of that.
Excellent point. And along with pride goes shame. Nobody wants to be shamed, right?
Yeah.
Shamed into making them feel bad. One of the other big issues is privacy. Hey, Jacob's shaking his head.
Well, I was
One
shaking
of-
my head. Sorry.
ahead.
Because I actually know people who will refuse to get treatment at our local hospital because they know people that work there.
That's exactly right.
And, small towns, small knit communities, information spreads. I mean, I know there's things like HIPAA, but in small towns,
Lack of anonymity is what's in your book. That's how we call it. That's what we call it. The lack of anonymity in rural communities creates lots of problems. Okay, so let's say, violence is increased in the rural communities, domestic abuse is increased in the rural communities, chronic diseases is huge in the rural communities. So we may not see a case of child abuse until the child is hurt and needs to come to the hospital, okay, or domestic abuse. They're just not going to seek out the care initially. They don't want everybody knowing about everybody's business. Okay. And same with substance abuse and mental illness is big in rural communities. We don't see these people until they're at a crisis level. Okay, same with disease progression. Okay, so let's say we talk about this in another class, but let's say you were the rural nurse and you've done your community assessment, you have kind of an unhealthy population. Let's say you're going to put together a health fair. How would you motivate people to get there? Why should they come? They haven't cared before. Why should they care now?
Prevention, being aware of like what could happen, especially with their health and their families.
Mhm.
So education too.
Motivation. So I guess my question is, how do you motivate them to really understand that why it's important to have a blood pressure screening? And if your blood pressure turns out to be elevated, further communicating what the risks of untreated hypertension are. Okay, I mean, that's a tall order. That's a heavy lift in a community that typically is not focused on primary health.
I think that sometimes you have to do incentives, because I'm actually from like a large city of Chicago, and I remember being in high school, and what they did was they gave out $50 gift cards, literally $50 gift cards for Walmart, Target, and Subway.
Mhm.
If you came in and just got like a testing or a screening. So everybody was like, I can get groceries, I can buy underwear if I just go get this. So it was more of an incentive that got them to do it, because sometimes, especially culturally, like a lot of my family are Haitian and they suffer from white coat syndrome, because sometimes they don't see a doctor until they're completely sick. So they think, if I go to the hospital, I'm gonna die, because most times since they're already sick and it has to be vital when they go, it's kind of too far along to fix.
Excellent point. Excellent. Incentives. Somebody in another class said free transportation or free lunch or whatever. Yeah, those are all great. Those are good incentives, but also it has to be really communicated to them how important it is to understand their health.
Target the
Understand-
wives,
What?
target the women in the population, go after the women, go after the moms, go after, the ones who can kind of bend their husbands or brothers or fathers' ear a little bit and have that influence of, hey, you should really go to this.
Mhm.
And get that kind of push going too.
Mhm. Let's shift to migrant workers. Migrant workers are typically part of the rural population. So we're just singling out a population within the rural community. What do you think of when you think of migrant workers?
They don't have papers, so they might not want to go for fear of deportation.
That when I ask about barriers, that's one of their barriers. Where
But
do
I think
migrant
also they think that they can't afford the care because you're also working and you make a certain standard of money. Like even if I'm sick, I can't afford the medication, so I don't even want to find out.
or even if you're to take that one step further, Devin, even if you're sick, you can't afford to take the day off to drive a couple hours for an appointment.
Yeah. One of the, oh, her husband didn't have papers actually, and he was eat up in cancer. He didn't go to the doctor over here because he, for one, didn't want to get deported. He had 5 kids that was born over here. He didn't want to leave them. He was taking care of them. And then by the time he found it, he was so sick, he couldn't afford to be cared for over here. So he got deported and ultimately he died in Mexico. But he had to go back just to get the care he needed because he couldn't afford it here once he did. It was too far along.
Mhm. Wow. Cool.
Plus, it could be
And then there's
also
mi-
part of their culture as well. Certain cultures, they view, their pride and everything very highly. So they don't want to be seen in that kind of, what's the word I'm looking for?
Vulnerable.
Vulnerable. Yeah. They don't want to be seen as vulnerable. I know in Hispanics especially, they call it like machismo, I think it is. Like macho man, pretty much. They don't like being seen like that.
Excellent points. Excellent points. And migrants, the majority of them do come from Mexico. And so some of them come alone, some of them come with families. You bring your family along as you're traveling through job to job in the migrant community. Think about all the risks for your family. What about the kids working on the farms? One of the biggest risks for the migrant population is pesticide exposure, right? So please, in chapter 24, please understand what pesticide exposure is. Okay, understand what the signs and symptoms are. Okay. What would be a primary prevention? Let's say you're working with a migrant population and the topic is pesticide exposure. What would a primary intervention be?
Maybe like washing your hands and washing your clothes.
That's secondary. What would,
Having masks available that fit everybody appropriately.
okay, yes, what are we educating them about?
About risks associated with the exposure to pesticides.
Right, right. And so let's assume that we have identified them as at-risk population. Then Rebecca hand washing comes in, Olivia masks comes in. What can we do to help them, prevent them from getting exposed? What kinds of things can we do to help mitigate that?
Proper use. How do you wash
Proper
your hands?
use,
How
maybe
you-
screening for pesticide exposure, talking to the people who own the farm. What are they spraying? Doing a history. And then what about tertiary? What happens if you're at a tertiary level of pesticide exposure? What does that mean?
Figuring out like treatments, and teaching them ways of coping with the illnesses that occurred from exposure.
So they have been exposed. And now they're symptomatic. Right? What else about the migrant? The migrant populations have a lot of the same health concerns and a lot of the same barriers as the rural population. Some of the other risks migrants face are housing conditions. And maybe they're living in crowded conditions with lots of families. What's that a prime risk for? Living in closed quarters.
TB.
TB, big risk. Okay. Kids kids of the migrant farm workers are very at risk. They're at risk for health access, they're at risk for illnesses, education, access to healthcare. A lot of migrants can't afford, like you said, Paula, a lot of migrants don't qualify for healthcare. Okay, and if they do, it's maybe a small subsidy. And just so you know, migrant workers do not qualify for WIC. Did you guys know that? They don't. And that's remember that. They don't qualify for a whole lot. And then lastly, the immigration status. What prevents them from going to see a doctor or going to a clinic or taking their kid to a doctor? Fear of somebody looking into their immigration status. Migrant work is tough work. Comes with a lot of stressors, a lot of anxiety, especially if you have your family with you. I mean, rural living is already tough enough. And then you throw your migrant population into as farm workers, and just creates a whole set of stressors and struggles. And then the other thing is migrant farm workers move. They move from place to place to place. So think about the continuity of care. Let's say they do go to a clinic and get seen for chest pain. What's the likelihood of that clinic going to the next, and they move to the next state? What's the likelihood of that information carrying along with them? Language barrier, cultural barriers, just tough. Okay, chapter 25 is about 4 very common vulnerable populations: poverty, homelessness, teen pregnancy, and mental health. Let's talk about homelessness first. What do you think is the fastest growing population of homeless?
The elderly.
Nope.
Veterans,
They're all vulnerable, but what's the fastest growing?
Single parents?
Nope. You're close. The answer is families. Families are the fastest group of homeless population. I saw this, even though I retired last year from my 20 years in the schools. Since the pandemic started over the last 3 years, the amount of homeless families skyrocketed. They estimate that there are over 600,000 homeless in our country every day. And the estimate is 1/3 of that 600,000 is families. That's a lot. Okay. And remember, when you read about the homeless population in your book, please be mindful of the different age groups. You know, how do toddlers react to being homeless? How do adolescents? How do high schoolers? How do adult children? Just be mindful of the needs. You know, let's say you're a homeless mom with 4 kids and ages, 2, 10, 15, and 24. I mean, everybody has different needs, right? Homeless families are very, very challenging. Okay. Adolescents in particular. I'm just going to talk about them for a minute. If they're living let's say they're living on the streets alone, what do you think their risks are? Violence, maybe
Drug-
domestic abuse. What else? Maybe an
Drugs.
early onset of sexual activity,
Human trafficking.
human trafficking,
usage of drugs,
drugs, substance abuse, mental health issues. We do have a lot of
STDs?
adolescent, pardon me,
Like STDs.
big STDs. Big, big, big. Let's talk about HIV for a minute. How is HIV transmitted?
Body fluid,
What did you say?
body fluid.
Contact with bodily
Body
fluids.
fluids? What about exposures to blood?
Yes,
Sharing needles.
needles,
needles.
needle stick.
Can it get passed down from mom to baby?
Yes.
Yes,
Who's at risk? What are the more common populations at risk for HIV? And we said the adolescent, yes, but who else? What about people who use IV drugs? Who else is at risk?
Would the infants be at risk?
What?
Unborn babies are at risk for contracting it?
Mhm.
People with multiple sexual partners.
Yep, that's one. Yep.
Would LGBT community be another one?
Yes. And there's one more group. It's the group that has recurrent STDs. Right? Let's talk about teen pregnancy. Okay, we know that single motherhood is increasing. Why do we think that is? What's going on?
They're not using contraceptives. They're basically having sex without condoms.
Mhm.
And no one's teaching them the correct way.
Lack of
Right.
education, social media.
And
Lack
they're,
of education is huge.
and they're so young. Some of them are. I know where I'm at. Some of them are. They're so young that even if you're educating them, it's not processing because maybe they don't completely understand the outcome of what's the consequence to the action that comes along with what you're doing.
Mhm.
Parenting.
Peer
What
pressure,
Pardon me?
peer pressure.
Peer pressure? What about living in poverty? Think that plays a role in decision making as well?
Yes.
I mean, we say throughout this class that the financial stability of a family, of an individual, is the most important indicator of health outcomes. Does that make sense? Think about it. If you are financially struggling, that affects whether it's an individual, a family, a teen who's pregnant, community. When you are, if you are not financially healthy, it affects every aspect of your life, right? From food to clothes to education to healthcare, job, providing basic needs. Okay, so for a teen pregnant mom, there's a direct there's a direct correlation between the lack of education and poverty. Okay. So if you were a school nurse in a high school and you had pregnant girls in the high school, and they were asking you, what should you do? Sure, it's important for you to keep your prenatal visits. Do you have a support system? Lots of things you can do. But the most important thing for a teen pregnant mom is to try and keep them in school. Okay, so if you're asked a question on the exam that says, what is the most important strategy when you're working with teen pregnant moms? Let's say the answers were good nutrition, prenatal visits, staying in school, and developing a support system. Believe it or not, the highest priority is keeping the kids in school. Not that the rest of it's not important, but there's a direct correlation with dropping out. Okay, poor teens are 3 times more likely to drop out of school. Okay, if you can find them programs that will help them stay in school, complete their education, it's just going to give them a better shot at a future for them and the baby. Okay, so again, there's lots of things we can do, but priority is to keep them in school. Okay, education leads to better outcomes, better decision-making, better choices. Okay, let's talk about mental health. Why is there such an increase in mental health issues, both with kids and adults? What's going on?
It can, honestly, from what I've seen working in an ER, is you'll see the physicians not really take the, situation seriously. So it gives people kind of like that, I don't know if I should say something because they might think of me this way, kind of like a gaslighting type thing. So it makes people feel uncomfortable to reach out to sources or to get resources because they don't want to be judged right off the bat because they're struggling.
And the resources for mental health is limited. There's not a lot of like therapists out there to can, provide care for them.
And
Plus therapy can be expensive.
Mhm.
and a lot of cultures, some cultures just don't believe in it, or consider it silly. Like it's not a thing.
Or there might be a stigma associated with it.
That as well.
Yeah. And what have we seen with kids over the last couple of years with the pandemic? When we took them out of schools and put them in their houses and
A lot of depression.
yeah. Isolation,
Suicide.
suicide amongst younger kids has increased quite a bit. I know when I was in the schools at the beginning, beginning and end of the pandemic, the issues with mental health were down into the low elementary school grades that were never there before. If you were a community nurse and you were trying to address the culture of youth violence, think of your ADPI, what would you do? What kinds of things could you put in place? I'll start. How about education classes for better parenting? What do you think about that? What else could you do? I mean, most communities now are seeing an increase in violence. Okay, lots of communities increase in gang violence. Lots of communities increase of violence in itself. We all have that in all of our communities. Okay, you're the community nurse. You're the public health nurse. What are you going to do about it? You can't do it alone. So
Did you
what are you
also-
going to do? Go ahead, Paula.
Do like support groups for people who have been in violence? I mean,
Mhm. Anybody out there in your communities, can they help you tackle this?
school counselors.
School counselors could help you.
Churches.
Who?
Churches.
Churches can help you. What about law enforcement? Can you partner with them? What about
Law
school?
enforcement, and then maybe a neighborhood watch. And I know my community has recently sent around this thing on Facebook. So we have an actual community Facebook page. But if more parents can kind of be like, I guess, like some neighborhoods have like a I don't know what to call them, like a night watch, or people in the community who go out and kind of provide support to the community. So it's just like more supervision. Sometimes the more supervision you have, the lesser things to happen. You know, you have more guidance in that nature as well.
And so what Darren's getting at is partnerships. That's what I'm trying to, that's what I'm trying to get across is partnerships. You can't do it alone. Okay, if you have a community issue of violence, which a lot of communities do right now, it's going to take a whole team to address that issue.
It's the whole saying, it takes a village.
Exactly. So one of the things, if you ever go into community nursing, and I did this all the time in school nursing, is you learn to network. You learn who your community is, who in your community can help you. You know, at the high school level, it may, you know, let's say there's an issue with suicide. And who can help you with suicide prevention? Maybe mental health counselors, maybe psychiatrists, whatever issue is going on with relation to mental health violence, you're able to seek out partners in the community that will help you. And there's a lot. So you got to figure out who needs a seat at that table.
I have a question about this. Because we had a situation where my oldest, we live a mile from the school that she goes to, and she used to walk to and from school every day. And she was dealing with 2 kids from her school who back and forth would bully her the entire way to and from school. We addressed it with the school. They said that there was nothing that they could do about it because it wasn't on school property. She wasn't allowed to have any kind of safety keychain on her because if she brought it onto school grounds, she would be, and it was found with her, it would be considered carrying a weapon with her. So she couldn't have that on school grounds with her. And we were in the situation where we have 1 car. I'm a full-time student. My husband works full-time, and we've got another daughter in another school who's younger, so she gets out at different times. And the only thing that we could do was completely rearrange everybody's schedules, because even though the school knew that these kids were bullies and had files on them about their behavior, because it wasn't happening on school property, there was nothing that they could do. And my daughter felt so unsafe, she stopped walking. She just.
So well, you already kind of answered my question. So what was option B? If the school
There was no option B. We had to find a way to get her to and from school.
Right.
And unfortunately, it's, you know, it's one of those things where the school only was going to take responsibility for what happened on the school.
On school grounds.
And we were able to find her a keychain with one of those high decibel alarms so that if they came near her, she would at least have that.
What about a school resource officer?
They are only posted at the very outside of the school.
Okay. So they were of no help.
Right.
Okay.
So we were kind of stuck in the position of, okay, if I drive her to school at this time, I'll be back so that my husband can go and do his work, because we don't have anybody else around who can kind of shuffle their lives around. Like these problems really are.
I mean, that's real. They're real. Absolutely.
And tough. And I think it's a shame that the school was immediately, no, there's nothing we can do. We won't help you, shut down. And instead of offering some kind of alternative or finding out if there was like a buddy system that they could implement or anything like that.
Interesting. Yeah. Wow. Thanks for sharing. Let's go to chapter 26, alcohol, tobacco, and other drugs. Okay. The one thing I do want you to review and make a little star next to it, is review the Healthy People 2030 box in chapter 26. Okay? So when you think of alcohol, tobacco, and other drugs, what kinds of problems are associated with all of that? What do you think about?
Addiction, like getting addicted to it.
Addiction, yep.
Also mental health as well.
Mental health, yep.
Dysfunctional behaviors.
Mhm. Violence, child abuse, domestic abuse, stigmas,
Suicide.
suicide. One of the
Overdose.
things that, what?
Not so overdosing.
Overdosing. Yeah, I mean, look at what's happening now with the statistics in our country of overdosing. What are your resources in your communities for any kind of treatment? You have treatment facilities, rehabilitation facilities, mental health services. What do these people do in your communities?
There are treatment facilities, but you still have to meet certain criteria as far as insurance. So it's the same thing as the hospital, depending on the criteria for your insurance. It depends on what kind of level of care you get, or if you get any care at all.
What if you don't have insurance?
That's what I'm saying.
What if you don't have insurance? What if you don't have it? What if you fall into the addicted, mental health? What if you don't have insurance? What are your resources?
The emergency room.
Mhm.
Yeah, I can say emergency room, but sometimes it's useless sometimes, because if they're not clinically like enough to get, like, you can get resources, but then there's some places that require like the insurance issues again,
Mhm.
where it again becomes a big factor. You can't get help because you don't have top-notch insurance, or or even if you do have government assistance programs like Medicaid, there's very rarely ever a program where they maybe might take Medicaid. It's either hit or miss, and then you're kind of like discharged, like, okay, I have all these resources, but how am I going to use them? How am I going to attain to them? So it's just kind of like a throw in your face, like, here, do what you want with it, sort of.
And then if you do one that does take the insurance you have, well, there was someone that came before you and their beds are probably full. So
Mhm. What kinds of things, what kinds of things cause people to go into the substance abuse, alcohol abuse,
depression.
maybe homelessness?
Can be
lot-
financial burdens, that plays a factor when you don't have money to pay your bills, and you just get
Traumatic event,
Yeah.
traumatic event in
Family.
the family?
Abuse,
family trauma.
neglect, that
Pardon
kind
me?
of stuff.
Say
Abuse
that-
and neglect, that kind of stuff.
Family divorce, death of a parent, death of a kid.
Participating in those activities with your parents or watching them.
Mhm. Mhm.
Peer pressure.
So when you look at this chapter, if you guys could just take a look at the different kinds of the categories of drugs, whether stimulants, non-stimulants, and the other drug I want you to focus on is nicotine. If you have a look at the nicotine section, okay, let's say you're working with a family, okay, and let's say you're working with a family of kids who have asthma and the parent smokes. Okay, and you're doing a home visit and your goal is to non-smoking house or whatever. Okay. What if the parent says to you, don't worry about it, I vape now. Is that okay?
The
No.
oils or the vaping is toxic for kids.
What is?
The vaping, the oils.
Oil, yep.
Vaping, it's toxic.
Remember what Rebecca just said, okay? If the parent starts talking about vaping, one of the things we need to make sure they understand, let's say you get a question that says, what's the most important point that we want to bring across to parents with regards to vaping? Maybe one is, it provides the same level of nicotine as cigarettes. You have all these answers, and one says the oil in the vape is poisonous, and the question asks, what's the priority teaching point? That's it. Does everybody know what I'm talking about? Okay, that, I mean, there's a lot of teaching points we can bring across, but if you're asked about what is the most important, it's the poisonous oil. Okay. Say, anybody have any questions about those 3 chapters? Let's just review faith community nurse. What's a faith community nurse? Nobody knows what a faith community nurse is? How about, here's another word to describe it.
Are
What's a
they like related
parish
more
nurse?
so to like churches?
Mhm.
Like they kind of like
They're-
give education to their congregation or something like that?
Yeah, a faith community nurse is a nurse that's works within the congregation. Okay, he or she brings a spiritual aspect of healthcare into the care. Okay, a lot of faith nurses are focused. Well, there's 2 models. There's 2 models of faith nursing that you need to know about. One is the congregational model, and one is the institution model. And pretty simple. If you're a faith community nurse working only in your congregation, okay, you're all by yourself, you're autonomous in your congregation, then you are working within the congregation model. If, however, your community is a large community and has a lot of needs, for example, and has a lot of resources, say, doctor's appointments and whatever, a faith community nurse can partner with resources in the community. Okay, so transportation, doctor's appointments, rec center visits, whatever. Okay, that's the institutional model, meaning they're partnering with community resources. So it's one or the other. You're either working autonomous by yourself, only within the congregation, or you are having to partner with outside community resources to help provide services. Some congregations are not big enough to be able to partner with outside organizations. Okay.
I've never heard of a faith community nurse. I've never
Really?
been one. Yeah.
Okay. And it doesn't matter what your place of worship is, whether it's a church, a mosque, a temple, it doesn't matter. Faith community nurses or whatever your model is. You've never heard of it, okay?
So are you a nurse like working for free for your
Maybe.
religion?
It could be volunteer, and actually it doesn't have to be your religion, your own personal religion. It could be another religion that you're educated about.
I was gonna say that too. I've never heard of one, but there happens to be a member of our church who is like a nurse. And so when we have like health events, she does end up, delivering information. Is that kind of like
There
the same
you
thing?
go. So she's your faith community nurse, Darren.
Gotcha.
Yeah, yeah. Very interesting role, very interesting. They do focus more on the primary prevention, like new families, new babies, health fairs, support groups, grief counseling, death and dying. Okay. As far as advocating, what do you think some of the biggest ethical issues would be for the faith community nurse? Think ethics here. What if you're working with a family at end of life and you're working with a client at the end of life and the family doesn't all agree on what's going on? What do you do?
See if the person has a will.
Mhm.
Power of attorney or a next of kin.
And if they don't,
Yeah, don't you
Spouse.
kind of have to respect their wishes, I guess, at that point?
Wouldn't you ask if the patient is married or if they have a spouse, like what they would want to do versus what the family wants? Or
Mhm.
is that something that like,
No. So I think, for example, of what are the kids or the siblings that just doesn't want to deal with it, can't deal with it, can't deal with end of life. I'm thinking hospice nursing now. And they're just totally disconnected. What can we do if you've read up on your hospice nurse preparation? What does the hospice nurse do? What's her role?
To keep the
Support and
patient as
comfort for the
comfortable as
family.
possible.
Pardon me?
I said to keep the patient as comfortable as possible. Like, you know, as a hospice nurse, you want to make sure that they're comfortable at their end of life stages.
Absolutely. And do you want their, go ahead, Jennifer.
Also their family, they work with the patient and the family.
That's exactly right. And so ultimately, you do want the family engaged, the whole family. So you've got some outliers out there that are not really agreeing or participating or are distant. You got to find a way to bring them in. Because ultimately, that's the goal for the hospice nurse, is bringing all the family members in together. What about the home health nurse? So let's say you're a home health nurse and you go out, you're doing a medication check. What other roles can you provide during that visit? What other assessments can you do? Think your ADPI.
Safety.
Can you do a safety check? What else can you do? What about environmental risk assessment?
Yeah, assess their like living. So like if there's mold or anything
Yeah.
like that, that could cause a condition.
Mhm.
Support system.
Support system. It's an opportunity to look at communication within the family if there's other members.
Would we
Did they-
use the I forgot the name already. We talked about it last class or prior to the exam, the environmental map or
Oh, your eco map?
yeah, that one.
Yeah, absolutely. One of the most important visits is from a home health nurse. And I say that because they have the opportunity to do so many different kinds of assessments. They say that the home health visit is one of the most important community health visits, right? Because even though you're going in there for one reason, you can accomplish 12 other things when you go in there. All right, you can look at the family dynamics of the parents and the kids, or the parents and their parents, or the elderly versus the children. Is it functioning or is it not functioning? Is everybody yelling at each other, or is things are calm and organized? Right? Let's see. What's the difference between Medicare and Medicaid?
Medicare is usually for 65, 60 ages of 65, or if you have a disability, and Medicaid is usually for like kids to government assisted program, or sometimes low income.
Mhm. Needs-based. Right? One of the big differences, that's right. One of the big differences between Medicare and Medicaid is the skilled care. Remember this, okay? You have to, in Medicare, you have to prove that the skilled nursing care, the nursing care you provided is skilled nursing care. So you're teaching a family how to change a dressing. You're teaching a family how to do the medication. It doesn't have anything, skilled nursing care doesn't have anything to do with ADLs. That's what I want you to remember about that. Okay. So for reimbursement, you will have questions about Medicare and Medicaid on your next exam. So I want you to make sure you understand who's eligible, 65 and older, and or disabled, and then Medicaid is needs-based. Skilled nursing care is skilled nursing care. It's not ADLs. Okay. Homebound status. Homebound status for Medicaid, it's required. They're not going to reimburse. Okay. Okay. And then There just one, why do you think lots of physicians don't accept Medicaid and Medicare?
Because of the reimbursements, they don't get
Reimbur-
much for it.
Reimbursements, exactly. Yep. Yep. So you need to understand the differences between Medicare and Medicaid, okay? All right, questions. I want to do a case study. Anybody have any questions?
Do assisted living fall under the skilled nursing?
Say that again?
Do assisted livings fall under scale?
It depends what you're doing. What are you doing? What are the skills that you're doing?
I'm saying like as a nurse in a assisted living facility.
A nurse in a what?
In an assisted living facility, which is basically just ADLs.
Yeah, no, that is not skilled nursing care. If it has to do with ADLs, it's not skilled nursing care. Right? But if you're doing, like I said, teaching the family how to change a wound, teaching the family how to give the medication, that's all skilled. Okay. All right, I'm not going to share my screen, but well, I can try it, but I wanted to bring up this case study without getting thrown out. Let's try and do this. Otherwise, I'm just going to have to read it to you. This is a case study about cultural competence with the rural population, the migrant population, and the Mexican community. All right, so it's asking you to know about, let me see if I can, see, I think it's going to throw me out. And I couldn't print it, I'm sorry. I tried to print the case study just in case this happened. So I can't share my screen. So I'm just going to read it to you, okay? Sorry,
Yes.
cut out for a minute. All right, let me. Okay, you're just gonna have to listen to this, okay? And then we'll answer together, all right? Whoops. Here we go. Okay, during a family home visit, Maria asks the public nurse why she needs a colonoscopy. After reviewing the documents, public health nurse tells her that she's positive for HPV. Everybody knows what HPV is, right? And her pap smear shows cell changes that could, if left untreated, develop into cervical cancer. A colonoscopy and biopsies are necessary to determine the more exact diagnosis and guide treatment. Right, to the public health nurse's surprise, Maria looks very stricken and begins to cry. After further conversation, public health nurse realizes that Maria, who is from Mexico, believes that she has cancer. Maria understands English very well, therefore the public health nurse does not need an interpreter. However, if they had, their remarks may have still been confusing because language is not only the difference between people from different countries, their cultural beliefs may not be the same. So the first question we have, and I want this to be open, what cultural beliefs may be causing Maria's distress? What do we know about the Mexican culture? And this was in your readings. What do you think?
I've known, like, I mean, from what I've seen, a lot of the Mexican like culture, they kind of just use like God as a punishment, like, oh, God is punishing me for this, or God is punishing me for that. So I think that can play a factor as far as culture goes.
Okay. What are your other thoughts? And remember, this is about this is also in the realm of the rural population, which has a large Mexican immigrant population. So think about it from that standpoint too. Why does she think she already has cancer? When we don't know that she does. She just heard that word cancer, that if we don't do the biopsies and the testing, she could be at risk for cervical cancer. Why has she jumped to the conclusion that she has cancer?
Language barrier.
Possible language barrier.
Has she been
Education.
exposed to some sort of chemical or?
What
Lack
about-
of education about the disease
Yep,
process.
that's what I was just gonna say. What's health literacy and health illiteracy? And I don't mean literate in general or illiterate in general. I mean, what's health literacy and health illiteracy?
Understanding how health works. And the
Understand-
progression of diseases and how things move.
And somebody from a different culture with limited language may have a hard time understanding what you're telling them. You know, she may have said you're going to need a pap smear and a colonoscopy and some biopsies because you may be at risk for cancer. What do you think she heard?
Cancer, so there's
Cancer.
like a medical terminology. She's not used to it.
Exactly. And that's a big issue. Well, it's a big issue in general, but a huge issue in the rural population is health literacy versus health illiteracy. And how do you assess that in every client you're taking care of, what their literacy level is? And then how do you explain to them, and how do you communicate to them so that they can understand? All right, here's the second question. How can mistakes based on cultural beliefs and misunderstandings like this be supported and turned into learning experiences?
Explain the process, what you're going to do, why you're doing it.
Mhm.
And also have her repeat it too.
And
Okay.
written.
So that she understands.
Okay,
And small, non-technical words.
okay.
The more
What
she's
about,
ob-
go ahead.
the more she's obtaining the information, ask her, do you understand this? Do you want me to repeat it in different terms? How, if there's a medical terminology, give her a different word or give her somewhat the definition of it so she understands better.
What about as a nurse, would you like to find out more about the culture, whatever culture you're working with? What if you have limited knowledge in the Mexican culture? Is it okay to ask?
Yeah, ask for an explanation. What does this mean to you?
Exactly. It's perfectly okay to ask with so much diversity that we have going on, and you in the nursing profession, you're going to be working with dozens and dozens of cultures, right? You can't expect to have the knowledge of all the different cultural values and beliefs and practices, right? It's perfectly okay to ask to find out more about their culture. Okay? How can we help you? How are we doing? And then we also, this is all about cultural competence. How do we know about our own beliefs? How do we assess our own values and beliefs about different cultures? Are we culturally sensitive? Are we culturally appropriate? Are we culturally in the know? Does that make sense? Because that has a big effect on how we care for different cultures. Okay, another question. What are some of the main cultural groups in the region or city where you live? What are some of the small cultural groups? So, what cultures do you guys live around? I'm from Denver. In Denver, there's a huge Mexican population. Huge. That's our biggest one in Denver. What about you guys? What are some of the cultural groups that you live? One other thing. When we were coming up here on Saturday, we had to take an Uber to my son's house from the airport to pick up the car. And we had a we had a driver. Our Uber driver was, and I'm in Minneapolis. Well, I'm in Wisconsin now, but we land in Minneapolis. He was a Somalian. He lived in the Somalian community of Minneapolis, which we know is huge. And so, of course, me firing my questions off. I'm always asking questions. It was probably a 15-minute ride, and I learned so much about the Somalian community just by asking. And he was more than happy to share about his community and where they live and how many are here and, you know, what his kids do. And so anyway, what cultures do you have living in your community? And do you engage with different cultures?
Maybe Jacob might be able to agree since I found out he's in the same area as I am, but the same thing, Hispanic, Mexican culture.
Okay.
And I think everybody kind of engages with their food. So it's 2023 and they have a lot of food trucks.
Yeah.
So,
Oh, yeah.
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 A lot of and then it's not just per se Mexican as well. Like we got a lot of, especially down here in South Florida, we have a lot of like the Cubans, Puerto Ricans. I've also been involved with quite a few of the Haitian group as well. Jamaican. Just varies on where you're at though.
Panamanians. Yeah.
Exactly.
Do you guys take the initiative to learn about different cultures in your community?
I do, especially working in an
Fascinating.
emergency room,
Yeah.
because when you get like all different kinds of patients that come in
Yeah.
from different cultures, so it's like it kind of gets me into that thinking like, okay, I want to understand why, you know, you guys do things the way. And I mean, like, depending on the situation, I don't like have a, I guess, a shyness in asking like, oh, hey, you know, do you mind explaining that to me? Because they honestly love explaining that because they're like, wow, you know, somebody else really wants to understand my culture. That's awesome. You know, so I personally like to really ask them and get to know and understand from their point of view, like working in an ER, because you see everybody and anybody. So
That's great. And even if you don't go into community nursing, whatever kind of nursing you go into, you're going to be working and dealing with different cultures, whether they're a patient in a hospital, somebody in the ER, somebody in your clinic, somebody in your community. And so I always think I always say to myself, this May, I will have been a nurse for 40 years. And this has been just an evolution over my whole career of developing cultural competence. And I'm still developing it. In the schools, we had lots of different cultures in the schools. So I was always tried to be proactive with families in learning about their culture. You know, why is it that we don't immunize kids? How can we, you know, protect the kids against pertussis if there's an outbreak? Learning what their values and beliefs and practices are. You know, working with the Middle Eastern community or the Muslim community about, you know, no meat in the school lunches, no pork in the school lunches. You have to be sensitive to all of that. Okay. Let's see. Okay, what's the next question I have for you? How can community nurses strive to incorporate different cultural beliefs, values, and practices into their nursing care without stereotyping or prejudging clients? Really important question.
All right, getting the patients involved, like asking them specifically about their cultural belief and their practice, because just because your culture has a certain belief, personally, you can agree to some practices and not all.
That's
And
excellent.
basically by educating yourself about the different cultures.
Right. Cultural knowledge. Yep. So asking the client, which we said, we could also help them find resources, right? Or no, we could find resources that describe the culture, right? We can do our own research. We could, let's say we worked in a let's say I worked in, let's say I was a community nurse in Minneapolis. I'm just going from the experience I had Saturday, meeting this Somalian Uber driver. Why couldn't, if that was a group I was going to be taking care of in the community, why shouldn't I go and attend community events in that community to become more comfortable and learn about it? Okay. Okay, a few more questions. During home visits, differences in concepts related to time can occur with clients. Okay, so there are different cultures that have different time. Time is more important. For example, Native Americans, they don't look into the future. They're focused in the past. So if you had a Native American family that needed to follow up with future appointments, since their time focus is in the past, they may need some help coordinating that. Does that make sense? So all cultures have different, some focus on the past, some focus on the present, and some focus on the future. So if Maria, we're going back to the client now, if she were part of your community, what health resources would exist for her? What information do you need to know before making any kind of a referral? What do you want to know? You're the community nurse, so you're expected to know what the resources are in your community. What are you looking for? Maybe what services are up. So she needs a colonoscopy and she needs biopsies. What are you looking for?
Nearby locations that offer these tests.
Does she have insurance?
Does she have transportation?
Does she have transportation? If she doesn't have insurance, are there places that offer those treatments for free?
She might also want to go to a provider who has bilingual capabilities, able to speak her native language.
Absolutely. So she has a better understanding. So think through. So what I'm trying to do here is, this is that part of Next Gen. We have the information. Now we're trying to apply it to clinical judgment. Okay, so all of nursing, the nursing profession, especially community public health nursing, is really focused on culture, right? We are in the community, we are going to be working with so many different cultures. So to be able to apply your clinical judgment into an actual scenario of Maria showing up at your clinic, she's ill, not ill, but she has some risk factors. She needs some additional testing. There is somewhat of a language barrier. She's not understanding what you're saying fully. You don't really have a great understanding of her culture. So how do you move forward? You can't just turn around and walk out of the room. So I guess I'm trying to let's think out loud about our AdPi. How would we help Maria? So that's what these questions are all about. So let me keep going. We have a couple more. So we talked about what we would be looking for. Who offers the service? What are the geographic restrictions? Fees, costs, transportation. Does she have any income? What's her immigration status? Right, that may affect her ability to qualify for programs and services. Okay, so the last question I ask you to ponder is, think about cultural practices and how they affect health and illness in your own family. What are your family's beliefs and practices related to illness prevention? What do you do when somebody gets sick in your family? What rituals does your family practice when somebody dies? Okay, so all things to think about. Okay. Is it helpful to go through a case study and actually put ourselves in a scenario? How would we help Maria? Look at all the barriers we identified. And if you don't know the answers to those questions to help Maria, where do you go? That's a real life scenario in the community setting. Okay. As I've been with Fortis, this is my 3rd year. One of the things that I continue to focus on more and more and more every term is cultural competence. Because the more I read, the more I research, my nursing journals and preparation for class, cultural competence, yes, it is lifelong learning, but cultural competence is a must in nursing. What if you get to a client or a patient that your beliefs just are so opposite of that culture that you're not able to take care of the patient or client? What do? Do you just walk away?
I think that, go ahead, Jennifer, I'm sorry.
You find a nurse that is able to be like your supervisor, and you have them find a nurse that is able to take care of their needs.
Mm-hmm.
You just don't abandon the patient.
Yep, perfect. Go ahead, Devin.
I was really going to build on what you were saying about how important it is now in medicine to have cultural competence, because based on the culture, it can really determine the person's care, because we look for like maybe the male to answer questions for a female, and they say it's, you know, like a form of abuse sometimes because they're answering it. But in some cultures, the man does speak for the woman in general.
Absolutely.
So it's not something that we can necessarily, you know, report as far as like aggression or violence within the home. It's cultural. So you have to have that ability to know different cultures or even religions, as far as like Jehovah's Witnesses.
Absolutely. And there are certain cultures that don't immunize their kids. And so I had to tackle that as a school nurse. I couldn't be judgmental. I couldn't be derogatory. I had to come up with a plan for the parents that if there was any kind of an outbreak, what would we do? How would we keep their kids safe? It wasn't judging that they're not vaccinated, because there's certain cultures that don't vaccinate. And the last point I'll bring up is, as nurses, the more we know and learn about cultures, whether it comes from your own research or asking the patient, we need to try and incorporate as much of the cultural values and beliefs and practices into their healthcare plan that we safely can. Whether it's food preferences, time, you know, focus on time, past, present, future, right? We don't just obtain that information just to be in the know. We obtain cultural information so that it can be part of their health plan. Right? So anyway. Okay, well, that's about what I have. Is that helpful last hour and a half?
Yes.
Yeah,
was
most
helpful.
definitely.
Yes, ma'am.
I you know what, I used to go to the book and show highlighted sections and all that. I really love to just have everybody on screen and talk about it. Just talk about it out loud, because that's the way we're going to learn. So, anybody have any questions? Devin, stay on after, please, for a minute, just for a sec. And there was somebody who emailed me this morning. Megan?
I also emailed you right before class to see if you still had any slots open.
Yeah. Go back to the, I'm meeting with one student tonight at 6 o'clock. And then I think I have a couple of slots open for tomorrow and a couple for Friday. And if I have to move into next week, I'll go into next week. But I already booked another meeting tonight well, I have to teach a class after this, but I already have another meeting I have to go to between the next class and my students. So you're gonna have to go into tomorrow. That's the long way of saying go to tomorrow.
That's fine. I put it in the email. If you'll just
Oh, good.
reply what time.
And then Megan, same thing. Go back to the email and find a time. Let's meet. Okay? Okay, and then Devin, stay on for a minute. I'm all done for the day. I hope you guys have a fantastic rest of the week. You know where to find me. Be looking for study guide 2 coming out this week sometime. And then you can, if you review the study guide, you'll have weeks 3 and 4 covered. And then next week will be the 3rd week. And so by the end of class time next week at this time, the whole study guide should be covered. You can start studying for exam 2. I know we're right on the heels of exam 1, but things are moving so quickly. Okay. All right. Well, you guys have a good week. You know where to find me. And
Thank you.
oh, you're
Thank you.
welcome. Good to see everybody.